Welcome, residents, to this explainer. Go ahead, pull up a chair, and get comfortable at the multi-headed microscope. I am absolutely thrilled to have you here today. As a senior hematologist, I can tell you right now that looking at a lymph node aspirate or biopsy is hands down one of the most exciting yet entirely humbling experiences in pathology. I mean, you are literally staring directly at the battlefield of the human immune system. Today, we're going to unlock the secrets of what we actually see under the scope. We're going to decode lymph node cytology together, specifically focusing on how to definitively separate benign, reactive inflammation from those terrifying, perfectly camouflaged mimics of malignant lymphoma. Here's our quick syllabus for today's session. We'll be covering 1. Clinical context and pattern triage, 2. Reactive versus suppurative patterns, 3. Identifying granulomatous lymphadenitis, 4. Lymphoma, the diagnostic traps, and 5. The diagnostic checklist. Think of this roadmap as your ultimate survival guide to avoiding the pitfalls that have, quite frankly, tripped up countless pathologists before you. Okay, let's dive right into Section 1, Clinical Context and Pattern Triage. Now, you might be wondering where the absolute first step of any diagnostic evaluation actually begins. Well, it doesn't begin by looking through the eyepieces. It begins with the patient. This right here is the golden rule of hematology pathology. Read it, internalize it, and literally never forget it. The patient's age, the specific site of that enlarged lymph node, and their clinical symptoms absolutely must anchor your diagnosis before your eyes ever hit the glass. Think about it. A massive cervical lymph node in a 6-year-old with a fever means something entirely different than a painless, slowly growing supraclavicular node in a 60-year-old. If you just jump straight in and order a massive panel of stains, hoping the diagnosis will magically reveal itself, you're just wasting time, resources, and you could potentially mislead yourself entirely. So once you actually do look down the scope, you need a branching logic. First up, is the sample even adequate? I mean, if all you have is crushed cells and blood, stop right there. Request more tissue. Second, drop down to low power and check the architecture. Finding an intact sinus structure usually points to a reactive benign lymph node, but if that architecture is completely or even partially destroyed, your alarm bells should be ringing for lymphoma. And finally, categorize the overall pattern. Are you looking at a dispersed sea of single cells? Are there tight aggregates? Or maybe the background is just littered with necrotic debris? Categorizing this initially prevents you from getting totally lost in the weeds later on. Moving right along to Section 2. Reactive versus suppurative patterns. Let's step up to the high-power objective now and meet your new best friend, the tingible-body macrophage. In a highly reactive fighting lymph node, your B cells are rapidly proliferating, mutating, and, well, frequently dying off via apoptosis if they don't produce the right antibodies. These specific macrophages swoop in to eat up that dead cellular debris. When you see them scattered throughout a germinal center, they create this beautiful starry sky pattern. Honestly, when you see that, you can usually breathe a huge sigh of relief, because they strongly suggest a benign reactive follicular hyperplasia. And this perfectly illustrates why those macrophages matter so much. In a typical reactive hyperplasia, you've got a really busy mixed neighborhood. It's polymorphous, full of totally different cell sizes, and loaded with tingible-body macrophages, just cleaning up the streets. But contrast that with a malignant follicular lymphoma. Notice the stark difference? It's a completely monotonous, cloned population of centrocytes and centroblasts. It totally lacks that starry sky appearance, because those malignant cells have basically stopped undergoing normal apoptosis. It's crowded, it's uniform, and it's incredibly dangerous. Now, sometimes you'll be scanning the slide and suddenly, bam, you hit a sea of polymorphonuclear neutrophils, microabscesses, and necrotic debris. This is your classic suppurative pattern. Your brain is going to immediately scream bacterial infection. And you know what? You'd often be right. This pattern is a hallmark of ordinary bacterial lymphadenitis, or if you happen to see stellate necrosis, maybe cat scratch disease caused by Bartonella henselae. But as a pathologist, you've got to keep your guard up. So let me pose a question to you guys. You're at the scope, you see all this abundant necrosis and swarms of neutrophils in the aspirate. Do you just confidently sign it out as a simple infection, recommend some antibiotics, and move on to your next case? No way! If you did, you literally just fell into one of the most devastating traps in hemopathology. Never ever assume neutrophils automatically equal a benign infection. Things like granulocyte-rich classical Hodgkin lymphoma or a neutrophil-rich variant of anaplastic large cell lymphoma can perfectly mimic a suppurative abscess. The actual malignant lymphoma cells can be entirely obscured by that massive reactive swarm of neutrophils. If you aren't actively hunting for those rare hidden neoplastic cells lurking in the background, you will miss a cancer diagnosis entirely. All right, let's pivot to section 3, identifying granulomatous lymphadenitis. Let's see how the immune system shifts from acute neutrophils to a chronic, specialized histiocytic attack. The foundational building block of a granuloma is the epithelioid cell. Think of these as activated macrophages that have developed abundant, pale-staining cytoplasm, making them look somewhat like epithelial cells, hence the name. When an antigen is just too tough to destroy easily, these cells cluster together to wall it off, forming a granuloma, and they frequently fuse together to form these massive, multinucleated giant cells. Once you identify these epithelioid granulomas, you have to look at the subtle background clues to figure out the root cause. For instance, if you see confluent granulomas with acellular caseous necrosis, you absolutely must suspect tuberculosis and order acid-fast stains. But look at toxoplasmosis. This one's fascinating. You won't see massive necrosis. Instead, you'll see small clusters of epithelioid cells physically encroaching upon and infiltrating hyperplastic germinal centers, paired with these bands of monocytoid B cells. And then there's sarcoidosis, which typically presents with beautiful, tightly organized, non-necrotizing, discrete granulomas. But wait, here we are again at the edge of another trap. You're looking at sheets of epithelioid histiocytes. You think to yourself, a classic benign granulomatous process. But I have to ask you, could these abundant epithelioid histiocytes actually be masking a lymphoma? The answer is a resounding, absolutely terrifying yes. Rushing to call it a benign granuloma without a meticulous search is a recipe for disaster. Hodgkin lymphoma is notorious for triggering an epithelioid histiocyte response that can literally hide the malignant Reed-Sternberg cells. Then you have Lennart lymphoma, which is a specific peripheral T-cell lymphoma characterized by abundant epithelioid cells. And, of course, T-cell/histiocyte-rich large B-cell lymphoma, where the actual malignant B cells make up less than 10% of the cellularity, getting completely drowned out by reactive histiocytes. Which brings us perfectly to Section 4, lymphoma, the diagnostic traps. We've talked about the mimics, but now let's focus on finding those malignant needles in the reactive haystacks. This right here is the monster lurking in the dark, the Reed-Sternberg cell. It's massive, atypical, and often binucleated with nucleoli so prominent they look like giant owl's eyes staring right back at you. Morphologically, they're stunning, but immunophenotyping is what confirms their identity. They're positive for CD15 and CD30, but uniquely negative for the common leukocyte antigens CD45 and mostly negative for the B-cell marker CD20. Finding just one of these monsters in a sea of reactive eosinophils or histiocytes, it changes a patient's entire life. But you really got to beware of morphological overlap. Take infectious mononucleosis, a viral infection. It can produce viral immunoblasts, sometimes called Downey cells, that look incredibly similar to Reed-Sternberg cells. They've got marked atypia and prominent nucleoli. So how do you tell them apart? Look at the background and your markers. IM has a reactive T-cell predominance with massive apoptosis and open sinuses. Hodgkin lymphoma, on the other hand, will feature true Reed-Sternberg cells, often surrounded by eosinophils, plasma cells, and crucially, thick bands of sclerosis or fibrosis. Plus, those viral immunoblasts will lack that classic CD15 and CD30 positive profile. So what happens when morphology is just too ambiguous? That's where flow cytometry steps in as your ultimate tiebreaker. But remember the golden rule here. It validates morphology. You never use it blindly. In a reactive node, flow cytometry will show a polyclonal population of B cells, basically a nice, healthy mix of kappa and lambda light chains. But in a B-cell lymphoma, the cells are all clones of a single malignant ancestor. Flow will detect a monoclonal immunoglobulin light chain restriction, meaning it's either all kappa or all lambda. That is the definitive proof you need to separate a stubbornly monotonous reactive pattern from a true aggressive neoplasm. Okay, let's wrap this up with Section 5, the diagnostic checklist. So the crucial point is, you simply cannot rely on gut feeling. You need a foolproof system for your daily sign-outs. Step 1, always integrate the clinical context before looking at the glass. Step 2, perform your low-power triage. Establish that the architecture is intact and determine that overarching pattern. Step 3, zoom in and find your cellular anchors. Are you seeing the starry sky of tingible-body macrophages, the pale clusters of epithelioid cells, or a sea of acute neutrophils? These anchors tell you exactly what kind of immune war is currently being waged. And finally, the most important steps to keep your patients safe. Step 4. Actively hunt for those mimics. Never let a beautiful granuloma or an obvious abscess lull you into a false sense of security. Scan the background specifically for atypical large cells, like those hidden Reed-Sternberg cells. And step 5. When you see a monotonous B-cell population, confirm your morphological suspicion with flow cytometry to definitively prove or disprove clonality. I want to leave you with this thought as you head back out to the sign-out room. The multi-headed microscope is a tool of immense power, but it ultimately only shows you what you're prepared to see. The next time you look through that scope and see a textbook classic infection, will you be the pathologist who spots the malignant mimic hiding in plain sight? Stay alert, stay curious, and never stop hunting. Thank you so much for joining me for this explainer.